Greetings from Team Indian Medical Association. I am Dr. K.K. Agarwal, National President-elect and Honorary Secretary General, Indian Medical Association. Welcome to our weekly show every Thursday 3 to 4 p.m. where we interact on a subject in association with IMA Webcast and Laborate, our digital partner. Today we are going to talk about an important subject, epilepsy vis-a-vis seizure disorder, and we have an expert with us today, Dr. M.M. Mehendi Ratta. He is a Professor Director, Department of Neurology at GB Month Hospital, and now he is on deputation as Director, Super Speciality Hospital at Janakpuri, New Delhi. Welcome to our show.
Thank you so much. Good afternoon.
Now, if we really want our GPs to understand few topics, epilepsy is one of them.
Yeah.
Epilepsy, acidity, hypertension, and diabetes. This can be your bread and butter. Because if you really can manage why all of them are more than 1% in the society, the prevalence is more than 1%. That means 1% of your practice, maybe more, should be on epilepsy. And if you don't know how to manage such cases and if you refer them, you are going to lose your practice. Therefore, it is very important to understand and these are the subjects which we take it up as a refresher for our physicians, practicing physicians in the country. Today, we are going to talk about an epilepsy, seizure disorder, more than 1% population, more than 1.3 crore people suffering from India, and more than 1 lakh in Delhi alone. Because we are sitting in Delhi alone we have more than 1 lakh cases. Therefore, stay with us for the next 1 hour, understand, write your notes, and don't forget, this video is going to stay on the IMA website for the next 1 year. So you can watch it again and again, and if you have not been able to watch now, you can watch it and send it as a gift to your colleagues so that they can also update their knowledge in the subject of epilepsy and seizure disorder. Dr. Mehendi Ratta, when I'm talking about epilepsy versus seizure disorder, what's the difference?
Yeah. Very good afternoon, dear general practitioners and family physicians. I will talk in very simple word, not for neurologists per se. The difference between seizure and epilepsy is seize means to be seized from outside. Seizure usually means single episode, which may be circumstantial or there may be underlying cause in the brain. Circumstantial, what I say, may be like febrile seizures, hyponatremia like low sodium. Epilepsy, when these seizures are recurrent, then it is called epilepsy. From neurologist point of view, we say when there are more than 2 seizures occurring or 1 seizure which is very prolonged, then only we label it as epilepsy.
So it is very important for us to label. This also has some medical legal implications. Specifically, it has a link with the stigma. We have mediclaim. In many diseases, if you label a seizure as an epilepsy, you may not get a reimbursement. A girl may not get married. A boy may end up into a stigma. So therefore, you need to differentiate that we do not call a person having epilepsy with a single seizure. Even second seizure, you can give a discount and still call it as a seizure disorder, and don't call them as epilepsy. What about the term fit?
Yeah, fit is a very loose term. Many people come with that, I have a fit or I had chakkar. Sometimes chakkar may be a seizure. Some people may be slumped to the ground, may also be considered as seizure, but it may be syncopal attack, which may be of cardiac origin. It may be a psychogenic fit. So fit is a very loose term. It's not used by the scientific fraternity. It is primarily more for lay people that there is a fit. And what Dr. Agarwal said, very important, seizure is not equivalent to epilepsy. If there are seizures because of fever, they are always called febrile seizures. They are never called febrile epilepsy. If there are seizures because of hypoglycemia, they are called seizures and not epilepsy. Same for hyponatremia, they are called seizures. And about these terms are commonly used like when there are psychogenic fits or seizures, we call them as PNES. Like they are not true seizures. Similarly, the seizures which can occur in stress may occur because of grief in the family. They are all pseudo seizures and not epilepsy.
So again, I'm clarifying it that we must know the classification, because we may end up into some reimbursement problem for the person if we wrongly label a person to be epileptic when he is not. Say in many of the Mediclaim, there may be an exclusion of epilepsy, but seizure is maybe preventable, maybe treatable, maybe secondary. Therefore, we need to have the correct diagnosis. And if we put a patient with hyponatremia, suppose he has seizures as an epilepsy, he may end up into a problem. So it becomes our duty to understand the correct diagnosis. I just said that 1% of the population. What is it figure correct? Or?
Yeah. Before that, I will say what Dr. Agarwal said. See, epilepsy occurrence or prevalence is 1% of the general population. Overall, all over the world, there are 65 million people who suffer from epilepsy. In India, on an average, we take 1%. It may be slightly less, but 1% rural, urban combined together. So in India, at any given time, there will be, say, 1 crore or 1.3 crore, at least in India. And as he said rightly, in Delhi, if we say the population of Delhi is 1.5 crore, so there at any time there can be 1.5 lakh people who are suffering from epilepsy.
So this is epilepsy.
This is epilepsy.
Seizure.
Yes. Seizures, that's what I'm saying. Seizures we don't count into occurrence, but on an average lifetime occurrence of seizure is 5%. So that's very high. Almost 5 times that of epilepsy.
So this 1% we are talking about?
Epilepsy, yes.
So which requires
attention
and treatment.
Yeah. And what other Dr. Agarwal said, that from medical legal point of view, other point of view, one has to be very careful. Proper diagnosis of seizure, differentiating seizures from other causes like syncope, epilepsy, is the responsibility of treating physician. What I have due regard, due respect, what somebody may think as a fit or seizure, epileptic seizure, may not be epileptic seizure in the mind of a neurologist. So for that, a proper diagnosis is very important, and if you are in doubt, consult your colleagues.
Okay. And again, when we are differentiating, can I reclassify epilepsy, because in my MBBS we got taught different classification.
Yeah.
Can we classify in the simple language a GP's epilepsy versus a neurologist's epilepsy?
That's right. You have heard of grand mal epilepsy, you have heard of petit mal epilepsy. What general physician or general practitioner will say, MBBS level, MD level, and focal. Now, but why there has been change? Grand mal and petit mal, both are generalized epilepsy. One is generalized, which is a motor, generalized tonic-clonic. The other is absence seizure or petit mal, which is also a generalized epilepsy. So then there was confusion. Oh no, it is a small, petit mal means small epilepsy. French in petite mean small. It's not small epilepsy. This is also a generalized epilepsy. Similarly, myoclonic jerk, where person doesn't lose consciousness, is still a generalized epilepsy. The other, what you have been using word focal, still stands true, but we prefer generalized epilepsy, focal epilepsies.
So generalized versus focal.
Yeah.
I still want to go back to GP's epilepsy versus non-GP. GP's epilepsy means they can manage, non-GP means they should refer.
I will say GP is the first person who receives the patient. In majority, whether stroke, epilepsy, headache, they are the key person. They have to recognize it. That this is if it is the most important, the gold standard is a good history. No investigation, can replace it. If you sit with the patient, listen to the patient, carefully see, not that patient says, मेरे हाथ पांव हिलते हैं, so I have generalized tonic-clonic seizure. That may occur even in psychogenic seizure or hysterical fits, what we say. So if you see there is a tongue bite, genuine tongue bite on the lateral side of the tongue, if there is a urination, if it is in middle of the night, if there is no circumstantial situation like too much of stress, then it is likely to be a genuine seizure. And if it is recurrent occurring, you can start treatment and send it to a specialist and get investigations, whatever are required. I am still not naming the investigation intention.
We will come back.
Yeah.
We will come back.
Yeah.
Then again, if I want to classify, epilepsy with loss of consciousness, epilepsy without loss of consciousness. Suppose I deal with epilepsy with loss of consciousness, how do I deal as a GP?
Epilepsy with unconsciousness are like generalized tonic-clonic seizure. Then absence seizures, or what you used to call it as petit mal. In that, the child may stand still for few seconds. And it may appear absent-mindedness. That's why these are called absences. Now he may have time gap in his routine. Suppose a child is sitting on the chair in the classroom. What teacher will say? Oh, you are very absent-minded. Now teacher may not recognize that this is a genuine problem. The child may be lost for few seconds and he doesn't take the notes. So he may lag behind other children. So this is with unconsciousness. Then there are like even some focal fits, like arising from temporal lobe, what we call temporal lobe epilepsy. There may be altered sensorium. May not fall. He is standing, but I will show if you want for that. Somebody may do like this. This is called automatism. This is called somatic automatism, hand automatism. And that time, if you slap the person or ask him what's his name, may not know, may not respond. So there is altered sensorium, but it's a focal epilepsy. But the commonest cause of loss of consciousness is generalized. Altered sensorium or confusion is usually occurs in focal epilepsy. That or too, only temporal lobe. While focal motor will be...
No, I recall my fourth semester, my first teaching which I got.
Yes.
And that was a person who comes to us with loss of consciousness.
Yes.
And then we need to decide, is it cardiac or neuro?
Yes.
Okay.
Yes.
So we used to ask simple question to the person, how did the person fall?
Yes.
It will be hypotonic fall or a hypertonic fall. If it is hypotonic fall, person will fall like this.
Yes.
And if it is a hypertonic fall, a person will fall like
in
this.
in hypertonic, usually in cardiac.
Hypertonic fall is cardiac.
Cardiac, necessarily not. There are atonic seizures.
Unless you have seizures.
Yeah. One is we have also to see the age. Suppose somebody gets at the age of 60 years. So first think of cardiac. He will slump to the ground. While on the other hand, a patient of seizure will fall on the ground. There is a difference. So a person with the seizures will be very stiff, like a log, like a wooden log, and he will fall on the backside or side, and he may injure himself. While cardiac patient who fall down will try to save themselves, and they will usually slump on the dining table or slump on the ground. They will appear very pale, and then pulse rate, if observed, can be irregular or those things.
So that's a way GP's tip.
Yes, GP's tip. Yes.
Tip which can come back.
Yes.
This. And then what are the preventable causes that we should look for?
Yes, preventable causes are very important, I think. The preventable causes are, I will say, first is the brain injury. The first and foremost in the peripartum period is hypoxic brain injury or perinatal injury. A proper delivery, timely delivery without obstructive labor and preventing hypoxia to the brain, also looking at the cord around the neck, is, I think, the most troublesome and preventable injury to the brain. That one.
So before that, we'll come back to this.
Yeah.
Namit Khanna, sir, can epilepsy be a genetic disorder? And then Rubina Khan, sir, what precautions should pregnant women take having epilepsy? Then Namit Khanna again, this is some, he's saying great information. And somebody, Piyush Agarwal, is talking about epilepsy surgery. We'll cover it up.
Okay.
And Hemant Arya, how is epilepsy treated? I think all of you who are watching, we will come back to all these questions. They are in our mind one by one. Let's go.
Yeah, I'll answer to Namit and all pregnancy, seizure, this. I definitely will answer, and very important. Thank you for asking those very good questions. So the first is avoidance of hypoxia to the brain. If it is more than 3 to 4 minutes, it's for lifelong. One has to take care. One may think hypoxia is gone, the brain may not recover. So hypoxic brain injury. Second important is head injury in young adults. We always say helmet. Sometimes we are very fancy helmet, or just to show, to avoid from the police, we just keep something black on the head, or a cap. That's not sufficient. That head injury is very important cause of epilepsy in young adults. Then third comes hygiene. What is going on these days, cleanliness or Swachh Bharat. Cysticercosis is very important cause of fits in children and adults in our country. Now some people used to say it's because of eating partially cooked non-veg. No, it's not. Rather it is more common in unhygiene situations. Suppose there are vegetables in your kitchen garden and those vegetables which are on the ground and there is a pig fecal matter contaminated and you think, oh, let me take it fresh. Just take it from there and eat it. That's not the right way. There may be fecal matter contaminated on the leaves or maybe in the like carrot, on the radish and other fruits which are on the ground level. So they should be carefully washed, very carefully washed and clean. And
Let me add here in our Vedic medicine, there is a description and that is Savan mein saag nahi, bhado mein dahi nahi. What does it mean? Savan mein saag nahi. Savan is a start of Dakshinayana and during this period you have rainy season, start of the rainy season with the Sola Somvar it starts and during this period we are not supposed to take leafy vegetables. Why? With the rainy season you expect that all the contamination will be much higher and at that time there is always a shortage of water shortage is there and rainy water, people feel that rain has come, therefore we don't need to clean that and they try to take raw vegetables and they end up into all types of helminthic disorders including neurocysticercosis. And that's what our Vedas also clearly describe about this description, Savan mein saag nahi.
Excellent. So primary is you have to take care of your brain. The mother, the gynecologist. So when we say take care means that means if you can't prevent it, then lifelong they will require anti-seizure medicine. Not necessarily that in everyone it will life. It depends on the intensity of brain injury, site of brain injury, means extent what I am saying. How much is the extent?
Suppose there is a head injury. Now how do I prevent?
Yeah.
Unless without giving the medicine.
Once there is a head injury, not that everyone will get a fit. But there are certain areas where there is a head injury, there is a break in the bone goes into the brain, or there is a contusion, they are the people who are more likely to get fits. So one is that, and then to recognize them early, and if they have any fit, what we were calling a seizure, first seizure, so then we have to take care. Now if it comes after 6 months of head injury, they will need treatment, even if it is a single seizure, because then it is likely to become epilepsy. It has left a scar. Like we get any wound on the hand or any abscess.
So whenever you suspect a scar, it's likely to recur?
Likely to recur and then treatment is to be given. Not that every patient who had injury must be given treatment for epilepsy. No. The answer is no.
So we will talk about investigation, but because most of the people are interested more in the treatment, we will talk about investigations later. Let's come back to basic management.
Sure.
First of all is that another tip which is going to come back is once the epilepsy or a seizure or a fit is over, emergency is over.
One should be always prepared, emergency may arise again.
No, but then that particular moment, shift.
No, if seizure is over, that doesn't mean seizure is over.
It's like a VT.
It may still come back and patient should be kept in the hospital for some more time.
It's like a VT, it's like a VF. Seizure is like in cardiology, it's like an arrhythmia.
It's little like more than that.
What I'm trying to say is, if a GP got a patient with seizure is over. Okay, now he has time to shift the patient, enough time. Yeah. He may not have to go along with the person.
Yeah, I will clarify to the GP.
Like emergency versus urgency.
Yeah. See, if there is a ventricular tachycardia, you do an ECG and you find the rhythm has become normal. Fine, that's good. But in cases of epilepsy, you are not doing simultaneously EEG. So if you have given the anti-epileptic drug, say intravenous something, benzodiazepine or some, the fit has stopped. That is only the motor component. But in the brain still there may be electrical activity going on, which you can't judge. So that will depend on the patient responses, and sometimes there can be non-convulsive seizure going on. That commonly happens in people who have stroke, who have TBM, who have status epilepticus. The status has stopped, convulsive status has stopped, but patient has not come out. So they may have non-convulsive status component. So that one must be kept in mind by the GP, and patient should be referred to the higher centers.
What is the first aid?
First aid is very important, and I will come, Dr. Agarwal will also mention myths and facts, I will come later. But first aid is whenever in general population I will tell first. For the general population, suppose it occurs on the roadside. Somebody falls from the bus. So it's the duty of the common citizens to see that there is not too much of crowd around the patient. There should be no object nearby which can hurt him because he is unconscious and he is convulsing. Then he should be turned on one side, say either left side preferably, on one side. Why? Whatever saliva or frothing in the mouth, that should trickle down. If he aspirates, then he will have aspiration pneumonia. Then after that is that if a person like me get a fit, or person like Dr. Agarwal, any of us who are suited, booted and with tie, so our tie should be loosened, collar button should be opened, and person should get an airy atmosphere. This is about this one. Don't force anything in the mouth. Lay people, I am talking about lay people. Now, as normally the fit will stop within 2-3 minutes. But the person who are watching it may be very horrifying experience. So at that time, if possible, doctor in the same transport or nearby, he should be called. Or then patient should be transported, preferably in a straight position. Straight means left decubitus, but on a stretcher, rather than lifting in the hand. Because he may have, you never know, fractured his vertebral spine, either neck spine or this. And then he should be transported, and the doctor should take care of ABC. This you know, I need not repeat that.
A for airway, B for breathing, C for circulation.
Yeah.
Everybody must remember that.
Yeah, so ABC has to be checked, and if possible put an airway so that he doesn't aspirate again. And then if he is still convulsing, then we have to give benzodiazepine. We have to give short acting, fast acting, preferably ultra short acting, like midazolam or lorazepam. As neurologist, I will say the data suggests lorazepam is a good drug compared to diazepam, because diazepam can cause respiratory depression. So lorazepam on an average in an adult 4 milligram IV to be given with a watch on the ECG and respiration. That's the first aid.
For a GP clinic, somebody gets a seizure, epilepsy, seizure is over. Now he wants to transport. Should he still give?
No, seizure is over, patient is becoming conscious, so then patient should be transported to nearby hospital. If suppose the seizure has happened for more than 5 minutes, that should be taken as status epilepticus, and it should be treated on that line.
So even if the seizure is over and it has more than 5 minutes, it is preferable to give him
lorazepam. Because chances of recurrence are high. Longer the seizure, chances of recurrence are high.
So GP can easily give lorazepam.
Lorazepam is by and large safe. They will have at least first aid facility in there. Any GP has to have in the office.
People don't keep lorazepam. That's what I'm saying.
Lorazepam.
So therefore, we need to recommend it as an IMA.
No, if they are taking as emergencies, they are taking, then they have to keep these things.
They may have, but
if they say we don't have amiodarone or we don't have adenosine, I think so. If they are seeing these patients, then these things may be required.
So in a GP clinic, we are talking about, because most of the people will give diazepam.
Diazepam can be given. It's not that it's a taboo now. It's not a taboo. But preferable is lorazepam over. Why? Now, everybody knows we give phenytoin for seizures. Now, diazepam is very short acting, and its metabolite desmethyl diazepam get deposited in the fatty tissue. And if you give too many shots, it may cause sedation later on and toxicity. While lorazepam action is somewhere between diazepam and phenytoin. So it's longer acting.
And what about phenytoin? Should GP be giving phenytoin?
No, I think if it is there, then GP should avoid. Family physician, what I say, MD people, MD friends should know about how to give phenytoin.
in their clinic.
In their clinic. With facilities available around, obviously. What I say, see, everywhere you will not have tertiary center hospitals. So they can make a mini ICU there. There's staff nurse who puts the BP apparatus. If they have a scope, fine.
So if in all the seizures, what is the drug of choice? If I have to use a simple drug common to everybody.
No, which seizure?
Let's say recurrent seizure and let's say first seizure.
Then like lorazepam in emergency.
So in first seizure,
Lorazepam. If you can't decide what's the type of it, what should I give, then valproate is the other drug of choice.
So no diagnosis, valproate.
Valproate, short term or long term. IV even status also we give valproate, and for prevention also we give. See, what I think the confusion is coming is two. First and foremost is termination of the seizures. That time is a seizure, don't take it as epilepsy. Termination of seizure, prevention of seizures. For that, phenytoin, valproate, and other drugs are there, carbamazepine or many, there are 20 drugs available. Then is third priority is to find out a cause. Not that seizure is occurring, you send for CT, no. That one. And fourth is prevention of complications. So these 4 points, if some principal knows, then it can be taken care.
So we'll again come back. So for termination, we are saying is lorazepam.
Lorazepam, midazolam, diazepam if nothing is there.
I normally, GPs always say there is no other calcium channel blocker than amlodipine, like that we teach them. So similarly, if I have to choose one drug, a person, then I say lorazepam.
As you asked that if it is terminated, we even advise sublingual clonazepam at home. Suppose some sublingual clonazepam 0.5 milligram, it's available. Sublingual you keep, and its action is very fast. The other option, very good for general physicians, is the midazolam spray. Midazolam spray is there, which they can put 3 puffs in the nose, alternate 1, 1, 1, because there is a rich capillary circulation in the buccal mucosa and in the nose. So it acts just short of IV. Like there used to be for febrile.
I think then at IMA level, our recommendation should be very clear. Sublingual clonazepam and spray of midazolam. And giving IV.
No, if they have facility, IV, which is definitely better. But if not, then midazolam or clonazepam.
It's not a question of better. It's a question of, in a hospital setting is different. In a clinic setting, if you give an IV injection, something happens. Okay, may not happen. It's always better to give if the effect is, even if it is 19, even if the effect is good, then it is always better for them to give
No, if in medical profession, first aim is to save the life of patient. Even if something happens, we have to be prepared for that. But we cannot give something which is very risky. We cannot give.
Is it risky?
Which one? No, that's very safe. That's the safest.
Therefore, we always say that those people who say an orthopedician, for him giving a sublingual will be easier than giving an injection.
Onset of action will be slower and delayed. That's why I am saying. Because main aim is to terminate the seizure at the earliest possible.
And then we can also tell the patients to keep it like a sublingual.
That even we prescribe. We give them like 2 preventive medicine and also give sublingual clonazepam to keep at home.
Whenever you feel like an aura, you take it.
You take it. Similarly, midazolam spray we tell parents.
So for me, it is like sublingual sorbitrate.
You can consider that. But for me, ideal is intravenous. Then when the ideal is not available, then best option is midazolam spray versus clonazepam sublingual.
Okay. So therefore, in a GP, you terminate and refer.
Yes.
Admit or refer or whatever you want. What about home care? So suppose the GP wants to treat a person at home. He is going for a home visit. He has terminated the seizure. Patient doesn't want admission, and he wants to provide a home care. Can he load now?
Suppose he is a known case of epilepsy. In those,
let's take first case, first seizure.
First seizure, he must refer to a heart center to find out the underlying cause.
Investigations are required.
Is mandatory. Underlying cause. If cause is apparent, then it is fine.
No, and you go for at the time of, suppose in the morning, 9 o'clock, he has seen a patient and he has seizure, he is now stopped. You can say, okay, I'll come with me, I'll get your EEG and MRI done.
No, even if he gets the EEG, how will he interpret the EEG?
No, the person who does the EEG will interpret. The center is supposed to give the report there and
no. If there is a recent seizure, it's better to observe in under this close observation of a doctor or a setup if it goes into status epilepticus.
So our recommendation is very clear. First seizure has to be no home care.
No home care.
No home care.
No, home care should be given.
No, home care means home admission.
That is pre-hospital care, and then patient should.
No. When I say home care today means admit at home.
No. That's
admission
not.
Means that you are covering a patient, you are putting a nurse and observing the patient in the hospital for morning and evening.
I think hardly anybody will do that, sir.
Not that everybody is doing it. No?
Not for seizure. For seizure.
See, most of us today are avoiding hospital because of secondary hospital infections. So therefore, home care now facilities are available. Who can create even an ICU at your home?
With seizure with short stay, no, they need investigation. They need the proper cause. In this situation, it will not apply.
Okay.
Like if patient has got MI, you cannot give home care. Epilepsy, again, if it is a recurrent seizures, is on established treatment, we should find out why did it happen. Like poor compliance is the commonest cause of occurrence of seizure in patient with epilepsy. First is compliance. That one has to see. Second, precipitating factor. Some stress at home, which may be physical, mental, or commonly that like many ladies or people fast. If there is hypoglycemia, that may cause seizure. So in those situations, they must visit the treating doctor and there may be step up in the medication if required.
Okay. And when to load now?
When to load? If there is a continuing seizure, or if the commonest is continuing seizure or what we classify as status epilepticus, in those cases we have to load. In addition to doing the ABC, taking blood sample for blood sugar, for any toxic substance, maybe alcohol or sodium in elderly people, we may have to load. In the form of first is lorazepam, 4 milligram.
4 milligram.
And then is phenytoin. Here, I think dosage may not confuse them.
No, relax it.
Okay, so then we can give phenytoin. In West, they prefer phosphenytoin. So we can give 20 milligram per kilogram body weight phenytoin loading. But it should be slowly loaded over, and then it should be a running IV drip should be maintained. A deep cannula should be put. And these two drugs may be sufficient. But suppose after giving phenytoin, many people use phosphenytoin. So it has to be a cannula, long cannula. Because if it extravasate, it may cause sloughing and necrosis of the skin. And with phosphenytoin, one condition called purple glove syndrome. The whole skin may become purple. So once you have done this, at that stage, if it is still not controlled, I will suggest, because there are certain steps which have been advised by the experts called Simon Shorwan from University College London, that step 1, 0 to 5 minutes, 5 to this minutes, 5 to 30, 30 to after 30. So in those situations, if still not controlled, patient should be referred to higher center. Then patient may require second line drugs. Now there are many other which are like simple drugs like sodium valproate, or we have levetiracetam, or even IV midazolam infusion are the choices which to be given. Then comes if it is not still controlled for 24 hours, it may call refractory epilepsy, or one entity called super refractory epilepsy, in status epilepticus. In spite of best efforts, nothing works. So in that patient may require phenobarbital coma. Thiopenton need to be given.
No. Why not valproate
as first line? First line. See, we have to give a medicine preferably which is IV available, and later on for prevention, same can be converted into oral. Phenytoin is not a great drug for especially for children, young adolescent girls, boys, pregnant women. They're not a good drug. So in those situations, certainly something else, like if for pregnancy, again valproate is not a good drug. There are neural tube defects or congenital defects, so should be avoided. In those situations, after lorazepam, levetiracetam, or there is another drug called lamotrigine, they may make a better choice. Or also, there are so many have come actually, even lacosamide. But at GP level, we should not burden them with so many choices. So it should be simplistic choice.
So therefore, when to give phenytoin, and out of this, the newer
if it is a generalized tonic-clonic seizure, phenytoin obviously will be drug of choice. We'll see if suits in prevention, fine. Otherwise, once seizures are well controlled, we may transfer to the other medication, which is safe.
Which one?
Now, like levetiracetam, in girls we don't give valproate. It causes like polycystic ovarian disease and congenital tube defects. In reproductive age group we don't. Try to avoid. Or if we have to give, there's no alternative, then we give in small doses. Then for elderly, valproate will be safe. For elderly people, if there is status, valproate will be safe, even levetiracetam will be safe.
So levetiracetam is coming as one of the drug of choice.
Levetiracetam is one of the drug of choice.
And that can be given
Almost in all types of epilepsy, all types of seizures or epilepsy.
So that's a newer drug. So as a family physician, we must identify one drug. So if I have to identify drugs for all of you, then lorazepam we have identified, phenytoin is continuing with that, and then we are identifying the valproate for the elderly and levetiracetam for all types of seizures. We must gain experience with that slowly, read about it, and you will get notes from us in our eMedi News, and we will we'll start creating protocols for GPs which can be used at a national level.
There is one I like to, sorry to interrupt. There is one guidelines by Indian Epilepsy Society. I am the Secretary General of Indian Epilepsy Society. We have guidelines called GEMINT. They were distributed to 10,000 API members. This is called GEMINT. GEMIND.
So give me a copy.
Guidelines.
No, I'll say other way around here. Now for IMA, give us the rights of those guidelines.
I'm not the first author. I'll tell you.
No,
yeah.
I'm not talking about it.
Yeah.
Reframe them for
Yeah.
GPs.
Okay.
So in your guidelines, you will talk about all drugs.
Yeah. No.
Let's talk about only one drug from each segment.
I'm
very basic level.
I'm coming to that. GEMIND is Guidelines Epilepsy Management in India. That is what GEMIND stands for. And my colleague, Dr. Satish Jain, it was by International Epilepsy Trust, which produced these guidelines. I was one of the members. So what you are saying will be very helpful for the IMA members.
So what I'm trying to say is, see, we don't want to talk about phenobarbital. We don't want to talk about higher treatment.
Okay.
We want to talk about at the very basic level, treat, refer.
It's given for general physicians.
If it is 4 pages, it has to be converted into 1 page.
Yeah. No, it's
Adoption from these guidelines for GPs.
It's a booklet. Simplistic approach has been given.
Okay, we'll send me a copy and we will try to find out what the GP should know as far as this is concerned. Now, we did talk about little bit quickly about febrile seizures, age-specific seizures.
I think there are a lot of people who want to ask questions which may be relevant, no? Because otherwise they will feel we have not answered to their queries. About the febrile seizures, now the febrile seizures are called situational seizures. It's because of fever. And these patients by and large don't need treatment on regular basis. In the past we used to give phenobarbital and this. First is termination of seizure, like earlier we used to say cold sponging. No, now not cold, only tepid sponging. Tepid sponging, interrectal diazepam became popular, but then it was not available. Thereafter came clobazam, is a very good drug for situational. I advise my patient domiciliary treatment, telling take note of, take cognizance of fever, cause of fever. I always say, okay, keep paracetamol at home, do tepid sponging. Clobazam, as per the age and body weight of the patient, say maybe 2.5 milligram BD for 3 to 4 days, may be good enough to prevent seizures. Similarly, during the menstrual periods, those are also situational seizures, and clobazam has been found to be quite useful for these types of seizures.
Sahil Khan is asking, is epilepsy common? We have already talked about 1% of the society. 2 questions have come from Arman Singh as well as from Sahil Khan. Is there any link of epilepsy with memory?
I think again, maybe they have seen somebody. If epilepsy is too prolonged, occurring again and again in spite of treatment, it may have effect on memory, what we call as refractory epilepsy. Second is that certain medications also may affect memory, though doctors take great care in not giving any medication which can cause memory deficit, but primarily is because of recurrent seizures. They may have their cognition, we call it in medical language, or memory, their personality, their behavior. They may become anxious, they may become depressed. So all these things are common in those who have recurrent seizures.
So nowadays, a lot of people are talking about surgery in epilepsy, and I have a girl who is writing to me from Panipat again and again that I've been advised surgery for my epilepsy. What is the role? Is it available? What are the results?
See, for all my, again, GP colleagues, medicine or medical treatment is not everything. By and large, 70 to 80% of patients with epilepsy in general will get controlled with medications. I'm saying controlled, not cured. But 20% of cases may be difficult to control, or what I said, refractory epilepsy, they may be considered for surgery. But before that, again I say, responsibility of the treating physician and neurologist to diagnose it correctly. Sometimes true seizures and pseudo seizures may be together. So a detailed history, gold standard, examination, not only review the investigation, but the neurologist should review himself also.
What do you do in the surgery?
The surgery, there are certain parts we try to localize from where epilepsy is arising. So even in generalized epilepsy, there may be a focus in the brain. Once we localize that by means of number of investigations, the commonest is EEG, second is video EEG, long-term EEG monitoring. Now there are advanced facilities other like magnetic encephalography. Then there may be certain investigation required, may be required SPECT and PET, means MRI also. MRI shows lesion. Suppose there is a lesion scar.
What do? You ablate it?
No, I am coming. That scar may not be the cause of epilepsy. The focus may be somewhere else. So we try to find out where the electrical activity is maximum, and then they try to remove that.
Surgically remove?
If it is accessible and not in eloquent area, should not cause more harm to the patient than benefit.
And is it being done in India?
It's being done in so many centers in India. It's called Epilepsy Monitoring Unit. They are available in All India Institute of Medical Sciences. At Shri Chitra, there is an institute that's very well known for epilepsy surgery. In Hyderabad, in Nimans, Bangalore, and there are a number of other private centers which are now regularly doing epilepsy surgeries.
Okay. So it is possible to do that.
Oh, it's very advanced in India now.
Then affect memory, then even I have a few questions. Pregnancy, just want to add something we have.
Pregnancy, we try to give it's not the pregnancy which matters. We say reproductive age group. Suppose a person is 16 years younger, so we'll give a medication which should not affect her when she get married and when she become pregnant. The commonest worry of the parents, especially mothers, they bring the patient when they are growing. They say, Doctor Sahab, now she is marriageable age, what should we do? So we try to give safe drug, and in that safe drug, we have recently, I was the editor-in-chief for Valproate guidelines, phenobarbital guideline, conventional anti-epileptic drug, that I will give you. I have given those guidelines. So in those we have given in what age group, what type of epilepsy, what's the best medication available. So in pregnancy, I'll give one example. Like Valproate is not a good drug. We should avoid, but there are sometimes compulsion. So then we give smaller dose. Then the conventional is given in others.
Okay. What about the cerebral atrophy leading to seizures in the elderly?
Seizures are very uncommon. Seizures are very uncommon in Alzheimer's disease. Only 5 to 10% of people may have epilepsy, and then they need to be treated accordingly.
What about unconventional therapies, Ayurveda, homeopathy?
You have asked the question to a wrong person. I am not the expert, and I will not like to comment. But there have been. We keep on reading reports.
Are there any trials available or trials going on in India?
Yeah, people have done on yoga, but about homeopathy and Ayurvedic, I am not fully aware.
What I want to say, for example, in refractory seizures, where you are giving a medicine.
There are dietary therapy. Here I will touch. there is a dietary therapy called ketogenic diet. Everybody knows about ketogenic diet or Atkins diet, modified Atkins diet. One of the diet even has been modified by our colleague from Bombay, Dr. Nathan. So there is a ketogenic diet in which there is a ketone formation. It's not a very palatable diet, but this is especially useful in refractory epilepsy. And in children and in adults, this has been used and extensively used when drugs are not having optimum effect. So we use ketogenic diet. Now there are ketogenic diet ready-made available in the market, but it's better the dietitian does customize to the need of that patient. Like South India, ketogenic diet may be different. North India, ketogenic diet may be different.
What about duration of treatment? When it comes to Medtalks.
There is no golden rule. Some people say 2 years, some people say 3 years. What's the basis of this? Basis is to calm that epileptic focus. Give it to such an extent that further dysarrhythmia, or what you call in ECG, the arrhythmias, here also there is cerebral dysarrhythmia. So that arrhythmia doesn't occur and the focus is no more discharging. So that's usually 3 years, but there's no hard and fast. Suppose there are no seizure for 3 years, I'll sit with the patient and family, take their consent, and if they agree, then I'll start withdrawing, not stop. Very good point for general physician. Not that after 3 years you can stop it. Many patients say, doctor will advise, take this treatment, come 2 months. Or they think they have to take for 2 months. If doctor forgets to tell that 2 months later you have to come to me for assessment, so they have to take in the very beginning they should say you will have to take for 2-3 years. And then time to time will tell how your seizures are going to be.
Withdraw it over 3 months?
Withdraw over 3 to 6 months, slowly. Yeah.
And if there is a relapse, then lifelong?
Necessarily not. If there is a relapse and there is some other cause for that, so may not be lifelong, but at least, once 3 years plus 3 years become a chain, so it may be required for longer period. Because if we say lifelong,
is there anything which is lifelong?
There are some epilepsies, especially called juvenile myoclonic epilepsy. Juvenile myoclonic epilepsy is a combination of generalized tonic-clonic seizures plus this myoclonic jerk. And they occur in early morning when they are woken up from sleep, or their sleep had not been adequate, or they had gone on a night function, marriage or some religious function. And they may also have certain other, I will not go in detail, but myoclonic and generalized. Whenever we see physician sees, he just writes grand mal epilepsy. Please devote time. Ask, are there any myoclonic jerk? Because their phenytoin is not going to be useful. It's harmful. It's detrimental. Phenytoin, carbamazepine is detrimental. So these patients may require valproate if indicated, if suits that person, or otherwise newer drugs like levetiracetam or lamotrigine.
What about
That is usually lifelong treatment, and that occurs usually in young adolescent group. Tics are usually physiological tics or habitual tics. They are not seizures. Tics, and once somebody may come, I'll show you. I don't know how many North India people may have some. What was that? Mungeri Lal ke Haseen Sapne. So he used to get this. This is not a fit. Many people, middle-aged, may have this. This is a hemifacial spasm. This is nothing to do with, it's not a brain activity, it is irritation of the facial nerve.
What do you do?
For hemifacial spasm, there are medication available, and then there are a botulinum toxin which is injected locally, or the brain surgery which is called microvascular decompression, because a vascular loop is irritating the facial nerve. So that vascular loop needs to be shifted from there.
Anything else we are missing? No? Myths?
No. Many a times it comes seizure, epilepsy and EEG. Not that EEG is to be done in each and every case. If clinically fits are very definite, even we don't get the EEG done. Today in my clinic, I may have seen around 20 cases of epilepsy who are coming for the first time to us. Maybe in 2 we got the EEG. Similarly, investigation, if patient can afford, I will suggest, even if it is a generalized tonic-clonic seizure, an imaging must be done in each and every case, where there may be focal cause. And MRI is the best investigation, and good quality MRI. CT scan may miss number of conditions, especially like cysticercosis, malformations. Now for general physician, one should keep in mind one entity called cortical dysplasias. It's coming in a big way, which is the cause of refractory epilepsy.
What is that?
Cortical dysplasia are like grey matter should be in grey matter, comes to the white matter. So there is migration of tissue. So that may cause seizures, and they may be very difficult to control seizures. And these may be the candidates for surgery. Yeah.
Other myths?
Myths and facts. Myths are that it is like, actually original definition was epilepsy. Epi means outside, epineurium, epicardium, something from outside. So it was considered as a result of some goddess. No, it's not. That's a myth. Fact is, it's an organic illness. It's a disease which cause is known. Similarly, myths are like, if we strongly hold the hand or the body, it will stop. You will only break the bones and the seizure will not stop. Next is putting something in the spoon or something hard or smelling as shoes or onion will abort the attack. No. Usually the attack aborts itself in 2 to 3 minutes. That is what nature has made. So all this, and then lot of people go for other traditional methods in villages, torture, and in Africa some pictures come. They are tortured badly with hot rods, electric rods. So that's a myth. That doesn't cure. Rather, it will complicate the case.
What about brain cancer and epilepsy?
Seizures can occur in brain tumors rather than cancer, I will say. The tumors are various types in the brain. The commonest which cause seizures are glioma and meningioma can cause seizures, and then they need to be treated accordingly, and underlying cause must be treated. Metastasis is another cause of seizures.
What about meningitis?
Meningitis per se, if it is pure meningitis, seizures won't occur until unless it has caused an infarct there or tuberculoma there. So like in TBM and tuberculoma together are very uncommon. So if seizure occur, then they need to be treated because there is a secondary cause. Similarly, if there is stroke and...
So in TBM you don't need to give them regularly?
No, not prophylactic. Only if it occurs. Similarly, stroke and seizures. If in first 24 hours of this, they may not require treatment, that will be stroke and seizure. But if it develops after a week or 2 weeks, then it is called seizures, and recurrent seizures will be labeled as epilepsy. Because that's because of scar of the stroke.
But if the stroke is presenting with seizure, one episode.
The commonest cause of seizures in stroke is the venous stroke. Where they are hemorrhagic stroke, they are usually in the cortical area because of the sigmoid sinus or maybe because of the sagittal sinus. Brain hemorrhage, again, around 20-25% people may have seizures, but brain hemorrhage usually are deep-seated in the basal ganglia, so they may not cause seizures. If they are cortical, then seizures.
In brain hemorrhage, no prophylactic?
Not in general. Not even in subarachnoid hemorrhage. We may have difference of opinion with neurosurgery colleagues, but as neurologist, I will say we don't give prophylactically.
So if you have to find out 5 take-home messages today.
Epilepsy is a common disease. It affects 1% of the general population. Many of the epilepsies are preventable. Most of the epilepsies are controllable. If not controllable, then surgery may be considered. But medical treatment is not the end of life. But there is other aspect like rehabilitation, vocational training, counseling, encouragement by the family and the society.
The time has come to wind up. I, being a mind-body counselor also, many people come to me and they say that, why me? Why my family? Why me? Why God is so unkind to me? I always tell that those who believe in Hinduism and those who believe in rebirth from other religions, that our purpose of life or birth is that we had to pay some debts of our last junk, and which we call them as a karma theory, and therefore some of our sufferings were left in our last birth, and therefore purpose of life, we are born to face those sufferings, and that also forms the basis of Buddhism. And when my purpose of life is to face sufferings, then we should suffer, not like, we should face suffering and not suffer from it. That means we should enjoy every suffering, we should pay thanks to the God that you have given me an epilepsy, but it is a treatable disease. Any treatable disease, we should thank God that you have not given me an incurable disease, you have not given me a disease for which I am going to die or suffer. Anything which is treatable, we should thank God for that, instead of cursing Him that why you have given it to me. And remember, epilepsy, seizures, all are controllable and manageable. And the very fact Dr. Mendiratta has said that this patient belongs to you for 3 years, 6 months off and wind off, many of them will come back to you for another 3.5 years, and these people will stay with you lifelong because they always want that I need prevention. That if they develop diarrhea, hyponatremia, if they become diabetic, you need to prevent secondary. So lifelong they may be your patient and they may be your bread and butter for lifelong. So learn about epilepsy, and then also learn about diabetes, asthma, hypertension, acidity, osteoarthritis, lumbar pains, cervical pains. These can be really 7 to 8, maybe out of 10 patients you may be dealing with them. And if you make yourself an expertise in that, you are going to win as a family physician. And before we close and say thanks to Dr. Mendiratta, we are having our 27th and 28th Central Council meeting, where I will be taking over as the National President of Indian Medical Association. All of you can join us. We will also have a live webcast of the Central Council meeting. We have lots of guest lectures also there. You can follow up with your local IMA branch to find out the details of the Central Council meeting. And 7th, and on this coming Monday, we are also having Dr. Shekhar Seshadri. He will be talking about child sexual abuse as a special webcast. And then following the next Thursday, we will have our routine webcast on adolescent health. Let's thank Dr. Mendiratta.
Thank you very much for inviting me. Thank you.
That's all for today. We will come back on this Monday with Dr. Shekhar Seshadri, an expert in child sexual abuse, and next week on adolescent health. Thank you very much. Goodbye. We'll meet you on this Monday.
Thank you very much.